we come to the next topic. Basically, my background and experience is more in the program development, in the stroke unit, stroke program development. When I joined my hospital in Frederick, Maryland in 2006, they asked me to develop the stroke program, and then from there on, I developed it, recertified, and another hospital asked me to become their stroke director. So between the three hospitals, every year there is a recertification or mock survey, or so that's my expertise to invite the visitors, the state and the Joint Commission, and so that's what they do. When they come, they see your processes from the EMS, how you notify the EMS, how the EMS notify you, how you educate. The EMS is emergency medical services. So here, like 1122. So 1122, which is the emergency call here. There's in America it's 911. Ashfaq sir, in Canada also 911. So 911. So that's our message to the public. That any time you have, so we educate them what are the stroke sign and symptoms. It used to be FAST, and we are educating that, and now it's BFAST. But so if you see that, then call 911, and then the EMS is educated that how to determine which person has a stroke and take them to the nearest certified stroke center. So that is a message that I was talking and thinking about myself, that unless the regulatory authorities and the governments and the Punjab government or federal government take it up, understand the importance of stroke prevention and stroke treatment, I think it's very difficult for us individual, Dr. Qasim, what he's doing, and us to change the whole system. I'll give you an example. When I joined Frederick Hospital, and they said, oh, you have to set up a stroke center, and for 2 years I'm after them and say, you hired me for that purpose, and so, but I don't see any activity. There's no stroke coordinator, there's no activity to set up a stroke program. And they say, oh yeah, we are serious, we'll do it. And they didn't do it for 2 years. And suddenly in 2008, they say, oh, we have to develop the stroke center, we have to create the stroke center. And I said, what happened? All of a sudden you're so serious, and then you hired the stroke coordinator and we started working on that. And then somebody told me that the state of Maryland had a regulation that EMS will pick up a stroke patient and will take it not to the nearest hospital, but to the nearest stroke certified center. And so they calculated that in 1 year they lost $2 million. So now all of a sudden they want to, because from Frederick they were taking to Hagerstown, Dr. Hafiz's hospital, and to Shady Grove and Carroll County Hospital. So and the patient they pick up from Frederick, and they will take not to the Frederick Hospital. So suddenly they are awake, and they within 6 months we applied. The state come in 2009 March, and we got it certified. So I think this is another message that if there's a will and the government, lobbying and all that, unless the Punjab government or the federal government mandate that there should be stroke centers, and stroke is important. It used to be the 3rd leading cause of death in America. Now it's 5th leading cause because of the prevention. But here, I think it's one of the, and all over the world, it's the #1 cause for disability. So that's all over the world.
Shahid, you mentioned about the emergency management services. So we have a ACL course. We go through how to recognize the emergencies. One of the video is in that the body stroke, and that video is shown to the public a lot. How the family to recognize the stroke coming. That is #1. I think that's the most important. Somebody has to take the initiative. Usually it's the family. They find out that mama ka ek balloon nahi jal raha hai, baat theek nahi kar rahi hai. That is so important. To educate people how to recognize those emergencies.
And that's why even though, and I commend the pathology people who are sticking to the guns and still present here, but I think the message is that even everybody, whether you're a pathology resident or no resident, or not even doctors, they should know what are the signs and symptoms of stroke, right? And in that regards, we are actually in Frederick. We are talking to the Frederick County Public Schools so that the middle schoolers and the high schoolers should know the FAST and BFAST, because if maybe that child is the only child who's at home and his parent or grandparent is having a stroke, and they are aphasic, they cannot reach to the phone to call 911. So who's going to call 911? Maybe that 8th grader or 9th grader. So it's so important, that stroke, that fascinates me always and keep me interested, because there are so many facets to the stroke care, from this basic message to the high end, what Dr. Qasim is doing here, taking out clot from the arteries. That's the fancy high end stuff, but it's a big spectrum of care. So that's what I said, that in America, in North America, the regulatory authority, the joint commissions, they even as back as 1997 started working on these different aspects of it. So what the regulatory authorities came up, that's how they evaluate a stroke center on 10 stroke core measures. That's what they call. So they have a form, they checklist, and they fail you. And each core measure you have to, American Heart Association has an expectations that 85% of the time you should meet all these core measures. Although in our hospital they say you have to meet 100% of the time, because, and that's better, but obviously at least 85% of the time you have to meet these stroke measures. So one of the first stroke measures is obviously thrombolysis and IV-TPA. So I'm not going to spend too much time on that, but the core measure is that if the patient comes to you, you have to give the TPA within an hour, within 60 minutes, right? So if the patient arrived by 2, you have to give TPA by 3. Now it's 4.5 hours, but this was the old saying. So if a patient arrived by 3.5 hours, you have to give by 4.5 hours. That's the IV TPA. So if you fail in that, one of our centers actually failed in that, and then we got dinged. So we say you got dinged, meaning that you may not qualify for the recertification. Or there's an honor system from the American Heart, American Stroke Association. When you go into the International Stroke Conference, your hospitals, they are advertising that these are the hospitals across the nation in America and Canada who got gold standard or gold medal, and then the different criteria that target stroke and all those core measures meeting. So it's a gold, a silver. So it starts from the bronze, gold, and gold plus. So it's an honor and prestige that your hospital has gold plus, and it's there in their journal, in their conferences. So it's like carrot and stick. So sometimes you get penalized, the hospital get penalized for not meeting these core measures, and sometimes you get the reward and prestige. So all these have the background and the stroke, the science behind them, that how this measure is so important. So obviously the 911 system, education, how to educate the public, the awareness, how to spot the signs and symptoms of the stroke, and then call 911. And so the pre-hospital is basically the pre-hospital care is the EMS care. Emergency medical services, I myself have given many lectures to the emergency medical services in the Frederick County, and as well as in the Montgomery County, which is my neighboring county. So educating them, and they attend all of our, we have a monthly stroke conference, our stroke meeting, and the EMS has a representative out there in charge in that meeting. So when we are deciding, this is a multi-system effort, so each one plays. So the pharmacist is there, emergency medical doctor is there, the hospitalist is there, the the hospital administration is there, and the EMS is there. So all those people, about 20, 30 people, once a month meeting and reviewing all the cases that we missed or we did not treat well. So, so again, that's what I mentioned, the EMS should bypass the hospitals who are not stroke centers. So that gave the incentive. So in Maryland State, there are about 63 hospitals. And at this point, I think about 57 are stroke certified. So almost 90% of them are stroke certified. When I started, I think there were only 13 that were certified 10 years ago. So again, the carrot and stick, here also the same thing. It has to be a will of the government or public or masses to say that we want this, a stroke is a serious thing, and we want an organized system across the whole city of Lahore or whole state of the Punjab or province of the Punjab. So again, like I said, I will pass by. This is all about TPA, so we all discussed, and it's related to the emergency medical services as well as the emergency physician and neurologist or neurology residents. But basically, the idea is the time is brain, and now there is evidence that every minute that you delay TPA, you lose 1.9 million neurons. 1.9 million neurons per minute you lose if you delay the care. So it's all about the timing. So all the small things that, yes, EKG or ECG is important, yes, the chest X-ray is important, yes, the troponin level are important, but do not wait for the TPA until, so if you do that and you're delaying the care or IV TPA timing, don't do that. Even labs, when we started, we had, from CBC to coagulation profile to a basic metabolic kind of, we would do all of them. But now nothing. No, if liver is normal, there's no liver disease in the patient, and there's no history of hypercoagulability, you don't need to check the PT, PTT, INR. The only reliable, consistent thing that you have to check is the glucose. And AccuCheck is the best way and fastest way to check that. But other than that, we don't go for the labs and don't wait for the labs. So again, non-contrast CT scan is, so somebody was saying why the CT scan. So basically CT scan we do not to diagnose stroke. We are not looking for stroke on the CT scan. We are ruling out the bleed. So obviously if the hemorrhage is there, we are not going to give TPA. Patient is already bleeding. So that's the purpose of the CT, not to diagnose the. And so now these new CT perfusion and rapid, like Professor Ashfaq was saying, those are for the later timings. Until 3.5 hours, 4.5 hours, the only thing is IV TPA, to give it quickly and then think about the later. The second part. So now we think about two parts. One is the patient is a candidate for IV TPA or not. That's the first question we have to answer. If the patient is a candidate, we have to give it right away. And then think about it. If so, we have developed, we have divided it into two phases. If the patient is still within the 6 hours, after giving IV TPA, we go for CT angio. And if we see the clot in the proximal vessels, then we send it to centers where people like Dr. Qasim or Professor Qasim is there for retrieval. In my hospital is primary stroke center. It's not a comprehensive stroke center. So we transfer the patient to Maryland or from Hagerstown, the patients are transferred to Pittsburgh, right, and or DC. So they fly over, within 15-20 minutes the patient is there. So the time is not wasted. Patient goes by helicopter. But that's the system, that not every hospital has the capability of retrieving the clot or removing the clot when we see it there. Yes, sir?
I will.
Okay, sir. So let's move to show what are the 10 core measures. So first was the TPA, right? The second is that the patient, or most of the stroke patients, have the dysphagia, meaning that they have difficulty in swallowing. So they should not be given medicine or food before we test that they have, because otherwise the food or drink will go the wrong way and will cause aspiration pneumonia, right? So that's why it's very important that before we give anything, we need to test whether they have competency in swallowing. So we can do it at bedside, give them, a tablespoon of water 3 times, and if they choke or cough, it means that they're not competent, right? So, and there's no harm with the distilled water or water. So, and then next day the speech therapy come and they do the bedside evaluation in a proper way. And sometimes we have to do modified barium swallow to evaluate this patient. But so that's the second. The third one is that we have to give the antithrombotics. So antithrombotics are both antiplatelets and anticoagulants. So right at this point we are talking about antiplatelets, which is aspirin, is the standard of care for the acute strokes is 325 milligram of aspirin, not Plavix, not baby aspirin. So that has to be given within 48 hours, within actually 24 hours. So by the next day, midnight, if you did not give aspirin, you are penalized for that. So that's the third stroke measure. The fourth is that you have to have DVT prophylaxis. Because as you know, initially, until the PT/OT physical therapist evaluate the patient, we cannot have them walk. So they are just bed dependent, right? They are lying down on the bed. And so they have a chance of developing the DVT. And DVT can lead to pulmonary embolism. So that can be fatal. So patient came with a stroke and you're treating the stroke, but patient can die of pulmonary embolism. So that won't be good, right? So this is on each and every stroke patient that they should be on DVT prophylaxis, which is of course sub-Q heparin or 5,000 or low molecular Lovenox or something. So that is very important. The fifth one is that every stroke patient should be evaluated by the physical therapist or occupational therapist, that what is their deficit, and from that acute admission, where will they go? Will they go to the acute rehab? Will they go to the subacute rehab? Or they will go home with the physical therapy evaluation. So there's a whole spectrum of that. So that's the determination of the physical therapist after. And so the latest guideline and evidence is to mobilize them as soon as possible, even if it means that from bed to chair. So transfer them from bed to chair and then evaluate them. So as soon as possible. The sixth one is that during their admission, and that's the high time that you have to educate them for the future, because the secondary stroke prevention does not start 1 month from now, 1 week from now. It starts right in that admission with the family, with the patient, the smoking cessation. Because as Dr. Ismail mentioned, that there is a list of modifiable risk factors, and smoking is right above them. So every patient has to be educated. If they smoke, obviously we put the nicotine patch so that they don't go into nicotine withdrawal, but that we have actually in our hospital a smoking cessation program, which takes them from that point to the next point and follow them as an outpatient. 7 core measure is the anticoagulation at discharge. So if the patient has atrial fibrillation, if the patient has a reason or indication for anticoagulation, fumidine or novel anticoagulant nowadays, then we have to start them. Obviously, there is a timing problem when to start them, and that's difference. It depends how big is the stroke. So it can be from few days to 2 weeks to 1 month. That's a separate topic. The 8th is that when each and every stroke patient should be discharged on antithrombotic, meaning either antiplatelets or anticoagulants. So if there's no evidence of atrial fibrillation or thrombus in the heart, then obviously the patient should be discharged on antiplatelets. usually is aspirin, but it can be aspirin plus Plavix according to the new trials, the point and the chance and faster, that the previously chance said that for 3 months we should give dual antiplatelet therapy, aspirin and maybe aspirin and Plavix. But with point, they reduced that acute period to 3 weeks. So 3 weeks aspirin and Plavix, and then after that it can be Plavix or aspirin. So the ninth is that everybody should be discharged on the statin. So that is very important. That has been evidenced by various trials, Sparkle and others, that patient who has even LDL above 100 will be on statin, or they were already on statin and you continue that. So any stroke patient, if they go out without the statin, there has to be a reason. So all these stroke measures that I said to you, if you do not give in the record, medical record, there has to be a reason why it was not given. If there is no reason and you did not give it, you will be penalized. So that's how we are checked. This is our exam, that how well we do at the hospital level. So the last one is the stroke education. That every patient who gets admitted with stroke needs to have the stroke education. So there has to be evidence of that. So there can be a brochure about the stroke sign and symptoms, modifiable stroke risk factors, diet and others. Or nowadays we actually give the patients a video. We show them the video while they're admitted. So there can be many ways. Or there's a booklet from NIH that can be given to the patient at the discharge. But there has to be a notification in the chart, in the documents, that this patient was given the stroke education. If there's none, then you fail that core measure. So we, all of us, we are checked. Every hospital which is a stroke certified center in America and Canada is evaluated on these stroke measures. So that's one way. There's other things, but this is definitely one way on which either you fail or you get bronze or gold plus award. Any questions? Thank you very much for your attention. Yes?
How long patients should on medication, like if a person is 48, he has a stroke, is his life to on medication? Or is the criteria after 10 years to 12 years we feel something and...
Aspirin is lifelong.
Okay. And other medication just like statins and thrombolytic.
So statin also, there's evidence that some, you can reduce the dose, but some, statin is beneficial to prevent the stroke. But obviously it can vary, and if it's too low, at some point you can do diet and exercise.
So the most of the embolic strokes, they're non-cardiac. They come from the extracranial vasculature. So is there any time to check the extracranial vasculature for possible surgical intervention?
Absolutely. So this carotid ultrasound or neuroimaging of the vessels is one of the main thing that we do during the hospital admission. So usually nowadays it's so advanced that the MRI, if we do the MRI, we do MRA of the head and neck, or we do the CT angio of the head and neck. So that determines if there is a atherosclerotic disease or stenosis, or carotid ultrasound. Because that's absolutely one of the secondary stroke prevention. If it's less than 50%, it's mild, and the medical treatment is best.
So how regularly should we get it done?
So once when the patient has a stroke.
So before stroke, as a preventive measure, how?
So the primary stroke prevention, there's no evidence that it, you can do it on every patient. We cannot do it on every patient.
On my own account, should I get it done once every year?
No. There's no evidence for the primary, even not for the aspirin. Like you said, okay, sure. Can I give myself aspirin, baby aspirin, to prevent a stroke? So that's called primary stroke prevention. So there's no evidence for aspirin or carotid ultrasound for primary stroke prevention. What we are talking about is a secondary stroke prevention. However, if risk stratification, if your risks are very high in your age, then I'm not sure, Professor Ashfaq, if we do
not carotid. Hypertension, smoking, dyslipidemia, atrial fibrillation. These are 4 proven primary prevention strategies. Then weight loss, exercise activity, treatment of obstructive sleep apnea. These are proven primary prevention. But aspirin, carotid Doppler, and treatment of diabetes. And diabetes, you may consider it for cardiovascular risk, but they don't work as a primary prevention. Secondary prevention, all of that works. But primary prevention, if you have to focus on hypertension, smoking, and if somebody has atrial fibrillation, treat that.
And exercise.
And exercise.
But sir, my question stands, if I am a smoker and I quit, मेरा एथिरोमा तो बन गया है।
नहीं, वो अच्छा हो जाएगा। 2 years, you need 2 years to decrease your risk. 5 years, your risk of stroke and MI is equal to a non-smoker. Your risk for malignancies do not change or do not decrease as much, but your cardiovascular risk is back to baseline in 5 years.
Okay.
So there is no age too late to quit smoking. If you quit at 85, by 90 years of age, your risk of going back to baseline risk is there. Correct?
Yeah. So if I can explain to your point, and this happens very frequently, and people like Professor Qasim sees them. What they do is, in Florida, as an example, somebody's put a Doppler machine, and you're going out in a mall, and he says, "Aa jao, tumhara Doppler karte hain." So you've got a Doppler, and you've got 80% stenosis, but you've never had any symptoms. Your risk of treating that surgically, or possibly medically, is more than managing those risk factors. So our philosophy, and then you gardan nahi morde phir, because you've got 80% stenosis, right? So we strongly urge and recommend it. Don't go looking for it, because the treatment, unless it's symptomatic.
No conflict.
And also, just generally, not even stroke or this, if you do 10 tests on a normal person, one will be abnormal. So then you're stuck. What to do with this? You don't have any symptom, you don't have any disease, and you did 10 different tests. One would be abnormal. So that's why.
Is it knowing better than not knowing?
No,
Not
that's
always. Not always.
Don't smoke and exercise.
So ignorance is bliss in many of the situations. So the principal rule of primary prevention is you do things or you investigate where after the investigation, your intervention has better benefit risk ratio, only then. So you do cervical pap smear only because you know that if you find something, you can manage it. But you do not do prostate biopsy on everyone, right? Even you should not do PSA now. They say there's no more harm than benefit. More people are treated. So if at the end, whatever you are going to achieve out of that information, you are going to help, only then do it. If you do not have a proven help, don't do it. Don't look for it. Don't ask for trouble.